Thank you all for being here today. As you know, this is CEC's observance of World Tuberculosis Day for 2013. Shown in this particular slide is the front cover of today's issue of the Morbidity and Mortality Weekly Report. And while I do not expect your vision to enable you to read the content of the front page, suffice it to say that the reason March 24th is the day we observe World TB Day is because 131 years ago, Robert Koch gave his lecture announcing the discovery of the bacillus that is known to be the etiologic agent of tuberculosis. And back then, TB was known as the White Death and was the cause of a lot of unnecessary mortality in Europe and the rest of the world. The other thing I wanted to share with you, if I can advance the slides, is the front cover of this month's Emerging Infectious Diseases, which is a theme issue devoted to tuberculosis. The front cover art is entitled TB Harlem, painted by Alice Neal in 1940, and it depicts a TB patient who was the brother of her then husband with the classic manifestations of tuberculosis. You see this emaciated individual after his thoracotomy, bandaged here. So back then what we had to offer before the advent of drugs was fairly destructive surgery as the way to try to address this disease. Much has changed over the years, and we in our country experienced a resurgence of tuberculosis between 1985 and 1992 that we've had to address. But the good news is that over the ensuing 20 years, we've had a return to declining trends of tuberculosis. And you'll hear more from Terence Lowe, the latest morbidity information. In 2012, states and territories of the United States reported 9,951 TB cases for a rate of 3.2 per 100,000. However, this still represents about 27 new diagnoses per day. And I'll pause here and say that I'm getting to the stage where I believe that my role in life is to educate the world about two things. One is, what's this uniform? Is that the Navy or you're a pilot? And I need to explain that I'm a career officer with the Public Health Service. No, I do not fly planes for Delta if I happen to be in my dress blues. The second is to explain to people that TB is still very much with us. For those of you who work on tuberculosis, I bet you that a very common occurrence when you tell people what you do is this still around? And yeah, I thought TB was gone. I mean, starting with my own family and to friends, I mean, talk about having to educate the world. So this is one of the new challenges that we face, and reflected today is going to be a realization of the need to put the face of tuberculosis back in the map. This disease has become a faceless disease, and we need to combat that general misconception. So having said that, I'm going to stop with my slides. I have about 3 other slides that I will share with you subsequently. But I'd like to introduce to you the presenters for today's observance. The first one is going to be Dr. Terence Lowe. Terry is an EIS officer assigned to the International and Research and Programs branch in the Division of TB Elimination. And he's been there since 2011. He received his Master's of Public Health degree from Emory University, doctorate in Public Health from the University of California at Berkeley, and he first became interested in international public health and epidemiology when he accidentally wandered into a medical entomology class medical years ago. He completed his dissertation work on a telemedicine and family planning project in rural Uttar Pradesh, India. Terry has also worked as an epidemiologist for California's Sexually Transmitted Diseases Control Branch and on various public health projects abroad in East and West Africa and South Asia. So, whoops, I picked up the wrong slide. Wanda, so the people know your story here. Terry, I'm assuming this is it. So, come on down, as they say. The floor is yours.
So, good afternoon. On this commemoration of World Tuberculosis Day, I would like to share some highlights of provisional 2012 data from the National Tuberculosis Surveillance System in the U.S. Since 1953, state and local health departments have reported new tuberculosis cases to the Centers for Disease Control and Prevention. This presentation summarizes reported demographic and risk factor data for 2012 TB cases. These data include reporting region, self-identified race, ethnicity, country of birth, HIV testing, and drug susceptibility results, excess alcohol use, homelessness, or resident at a correctional facility. TB rates are calculated using population denominators available from the 2012 Current Population Survey and the U.S. Census Bureau population estimates. In 2012, a total of 9,951 new tuberculosis cases were reported in the United States, an incidence of 3.2 cases per 100,000. This is 6.1% lower than the case rate of 3.4 in 2011. Although this figure only shows the reported number of TB cases annually since 1982, the 9,951 cases reported is the lowest number since national reporting began in 1953. The rate of 3.2 cases per 100,000 is also the lowest rate. 2012 marks the 20th consecutive year of declines for both the reported number of TB cases and the rate. In 2012, all states in the District of Columbia reported at least one new TB case. Individual state TB rates per 100,000 population varied widely and ranged from 0.4 in West Virginia to 9.0 in Alaska. 33 states and DC had lower rates in 2012 than 2011, and 17 states had higher rates. In 2012, California, Texas, New York, and Florida reported more than 500 cases. Combined, these four states accounted for 4,967 TB cases, representing approximately half of all TB cases in the United States. Among the 441 counties in these four states, 136, or 30.8%, did not report a new TB case from 2010 through 2012. From 2010 through 2012, 44.2% of the 3,143 counties in the United States did not report a new TB case. As mentioned prior, all states and Washington, D.C. reported at least one TB case in 2012. In 2012, the greatest percentage of TB cases by race ethnicity were among non-Hispanic Asians at 31%. The second highest percentage were among Hispanics at 28%, followed by non-Hispanic blacks at 22%. From 2011 to 2012, however, TB rates decreased among all race ethnic groups. Hispanics had the largest decrease of 9.1%, followed by a decrease of 7.4% for non-Hispanic blacks. Disparities in TB rates continue to exist between whites and racial ethnic minority groups. In comparison with non-Hispanic whites, rates were 25 times higher for non-Hispanic Asians, 7.3 times higher for non-Hispanic blacks, and 6.6 times higher for Hispanics. In 2012, 3,666 TB cases were U.S.-born and 6,243 were foreign-born. Both the number and rate for U.S.-born and foreign-born decreased from 2011 to 2012. For foreign-born TB cases, the decrease of 8.6% in the rate represents the largest decrease since 1996. This figure shows both the number and rate of TB cases among U.S.-born and foreign-born persons from 1993 through 2012. In 2001, the number of TB cases who were foreign-born TB cases, depicted by yellow-colored bars, surpassed those who were U.S.-born, depicted by red-colored bars. Although TB cases and rates decreased among foreign-born persons and U.S.-born persons, foreign-born persons continued to be disproportionately affected. In 2012, the rate of 15.8 TB cases per 100,000 population among foreign-born persons represented a 54% decrease since 1993. And the rate of 1.4 TB cases per 100,000 population in 2012 among U.S.-born persons represented an 81% decrease since 1993. In 2012, the TB rate among foreign-born persons was 11 times higher than U.S.-born persons. In 2002, it was 9 times higher. And in 1993, it was 5 times higher. While TB rates among U.S.-born and foreign-born persons both decreased from 1993 through 2012, the decline among foreign-born has been slower. In 2012, 63% of all TB cases occurred in foreign-born persons, while 37% were in U.S.-born persons. In 2002, 51% of all TB cases occurred in foreign-born persons, while 49% were U.S.-born. In 1993, 30% of all TB cases occurred in foreign-born persons, while 70% were foreign-born. 70% were U.S.-born. Since 1993, we see a progression in cases who were foreign-born. Among persons with TB, 96% of Asians, 75% of Hispanics, 40% of blacks, and 21% of whites were foreign-born. Among U.S.-born persons, blacks were the racial ethnic group with the greatest number of TB cases. The top 5 countries of origin for foreign-born persons with TB in 2012 were Mexico, the Philippines, India, Vietnam, and China. Combined, these countries accounted for 55% of TB in foreign-born persons. In 2012, 82%, or 8,119 of 9,951 TB cases had HIV results. Among those with results, 7.7% were co-infected, represented by the green line. Among those aged 25 to 44 years, 12% were co-infected, represented by the blue line. In 2011, 1.6%, or 127 of 7,817 culture-confirmed cases with susceptibility test results for isoniazid and rifampin had evidence of multi-drug resistant TB. 85.8% of MDR TB cases were among foreign-born persons. In 2012, there was 1 case of extensively drug-resistant TB. Other risk factors for TB cases include being homeless, using excess alcohol, and being a resident in a correctional facility. Among the 9,396 TB cases who were 15 years and greater and with known risk factor status, 5.6% were homeless, 12.1% had excess alcohol use, and 4.2% were residents of a correctional facility. In summary, 2012 represents the 20th consecutive years of decline in TB cases and rates in the United States. The rate of 3.2 cases per 100,000 is an all-time low, and the number of cases is under 10,000 for the first time since standardized national reporting of TB began in 1953. In the United States, the geographic distribution of TB cases is heterogeneous, both among states and within states. 44.2% of counties in the U.S. do not report TB cases, and foreign-born persons and racial ethnic minorities continue to be affected disproportionately. I would like to thank the following persons for their assistance. Thank you.
Thanks, Terrence. You may want to join us up front here, please. We will have a period for questions and comments at the end of the observance today. In looking at the room, I need to notify you that unlike the Atlanta Symphony, the front seats are not any pricier than the back seats. Ergo, I recommend that you move forward closer. Let me also invite Wanda to the podium Dr. Wanda Walton is the chief of the Behavioral Studies and Education branch. Wanda leads the group of professionals in our division who are charged with the activities as implicit in the title of her branch. Wanda has a master's degree in education, a PhD from University of Alabama, and is one of our behavioral scientists with expertise in health education and a subject matter expert in tuberculosis. I was just asking Wanda, how long have you been in the branch? Because both of us have been around for a while. So she's a teenager. She's been the branch chief for 14 years. Wanda, please.
Thanks, Ken. Good afternoon. I'd like to tell you all about an exciting project that we've been working on in our branch, and it's the TB Personal Stories Project. So why did we start this project? There are a number of reasons, so let me run through a few. Personal stories are effective means to move beyond the numbers and connect with our audience. It's a way to demonstrate the importance of what we do, document real events and real people over time. Personal stories can be very motivating, and they can show someone something that they would never have an opportunity to see in real life. But for us in TB, the real bottom line is that with the decreasing incidence of TB, most people in the U.S. have never known anyone who had TB, nor do they understand how debilitating this disease can be. So staff in our branch have been working on the TB Personal Stories Project with the goal of raising awareness about TB in the United States, that TB still exists and it poses serious health consequences if not controlled, that real people still get TB every day and have been helped with treatment, and most importantly, public health provides the critical support patients need in order to be diagnosed and cured of TB. And one of our program consultants said it also really gives meaning to show what we have been doing and that it really is about real people who have been affected by the work we do. This project could not have been possible without the help of the DeKalb County Board of Health, Gwinnett, Newton, and Rockdale County, and the health departments from Texas, South Carolina, and Georgia, because those are the programs that helped us with this initial effort for our stories. The TB personal stories are in both written and video formats. They are on our website right now, the written stories are. We currently have highlights of 8 personal stories of people who were treated for TB disease or for latent TB infection. And this is just an example of one of the stories. This is a family from South Carolina who adopted 2 children from Ethiopia. It turns out that one of the children had multi-drug resistant TB. And they credit the treatment and the positive outcome for their child from the health of the South Carolina TB Control Program, specifically one of the public health nurses. We do have a video that we are working on, and I have to give a little bit of a caveat in that we are still working on it, refining it, and improving it. But it is still an excellent video, and I want to share this with you today. There are 3 patients who were profiled in this. Santos Triandeo, who gave generously of their time and efforts, and also the health departments that we worked with here in Georgia for these videos. They gave of their time and gave up their conference rooms and their staff for us to be able to do this. So as I was instructed, I'm supposed to give the magic words of roll the video right now.
In the United States, the number of tuberculosis cases has been declining since 1993. However, TB is still a life-threatening problem in this country. TB knows no borders, and people here in the United States are suffering from TB. Researchers at the Centers for Disease Control and Prevention, along with other partners, are striving to make the world free of TB. By working together to detect, treat, and prevent TB, we can reach the goal of TB elimination. Anyone can get TB. This video highlights the personal stories of several people who were diagnosed and treated for TB infection or disease. These are their stories.
I first found out my younger brother had TB, and they did a investigation with the whole family and everybody that he was in contact with, and then they called me to the clinic to screen me. And after the screening and the chest x-ray, they ruled out that I had tuberculosis, that I had the actual disease, and that had to be put on isolation and treatment.
The first thing when I found that I got TB, it was not easy to find that I got TB because it was sick for a long time ago before I found that I have a TB. I used to be, I got my doctor, regular doctor, but they never give it to me something or tell me if I got TB. I had to go to the hospital, and when I get to the hospital, it was like, they never tell me exactly I have a TB, but after the 3 weeks, they tell me I have a TB.
I found when I entered United States in April 12, 2012, here is a process that I need to go through the health screening. So when I come to attend health screening in DeKalb County Board of Health, it is in Decatur, Georgia. So at the time, the health professional over here, they draw blood from my body and they test for TB. And the test was named as a quantiferum test, and through that test I come to know that my body was exposed to TB.
Tuberculosis is a disease that damages the lungs and other parts of the body. In the past, it used to be called consumption because of the damage and weight loss that it caused in people. Most commonly, people develop cough that's productive of phlegm, night sweats, fevers, and weight loss. And these are the symptoms that characterize this disease.
My symptoms were a lot of coughing, fevers, just mainly PM fevers, and night sweats, and just loss of appetite. Nothing was tasting good at all. I would take 2 bites out of everything and I would just be full.
Well, my symptom was fever, cough. When I cough, I got blood also, and sweat night. Also, I got weakness, tired. I can eating also because I lost appetite. I lost weight. There's a lot of things happen in my life at this time.
At that time, I just started school. I just finally got into school, and as soon as I was in school for about 2 to 3 weeks, I was diagnosed, and that forced me to quit school and also quit my job.
The hardest part is because I got in my treatment, because I got a lot of side effects.
The difficult thing is that I was not in a position, and doctor will have a tough time to explain me about latent TB, and until I was convinced, he tried to convince and he educated me about latent TB. I think that was the very tough time.
Well, there are 2 forms of tuberculosis. Right after infection occurs, most people have what's called latent tuberculosis. As the name implies, these persons have no symptoms and are usually found through screening tests for tuberculosis with either a skin test or blood tests that are now available. People with latent tuberculosis carry a risk of developing TB disease, or the active form as we also call it, and there are drugs that are used to prevent them from progressing.
The health department was very supportive. The case manager at the preventive clinic was very, very helpful. And also the American Lung Association was very helpful, and they helped my family get through this, and the case manager, Hua, she helped us a lot with everything, with getting in contact with the American Lung Association and just supporting me through my treatment. The American Lung Association was able to help us with our house bill because so many people in one house was diagnosed with the disease that they were able to help us with just groceries. They gave us just cards for groceries and to help us pay with our house bill.
The local TV, they helped me a lot because they, first one, they helped me with to understand what's the TV. And also they helped me out with a lot of things about when I don't have a right to come in to take my pill because I had to come in every day over here.
He prescribed me the medicines for 4 months, and the name of medicine was Rifampin. I hope now my body is free of TB germs, and I'm very happy to be without TB germs.
In the U.S., about 10,000 people are diagnosed with TB every year. That's about 27 cases every day. This is a concern because this is a transmissible disease, and anyone who has TB who's not found and cured will continue to transmit the disease to others. So the key role of health department programs is to help identify, screen, and treat persons with tuberculosis in partnership with others in the community as well as with the patients who develop tuberculosis.
My case manager, Hua, was very supportive through my treatment, and she kept in contact every day. She made sure I was okay every single day, and my brother and my family was very supportive because he as well had the disease, and it was me and him that were on isolation, so we were both just at home, just us two playing video games and just keeping each other company basically through the whole treatment.
I'm motivated with my family, and also I'm motivated because I want to be healthy.
I was having very strong willpower to get rid of the TB, and that's the reason I was sick, and I was motivated like that to complete the TB, and my family support, and I would like to thank them because they support me very well, and the whole unit of DeKalb County Board of Health, I mean TB, latent TB as well as TB unit over here, they support well. And that's how I was motivated.
My advice for somebody that just found out they had tuberculosis is don't panic and just follow the treatment and take your medicine every single day and just be consistent with it.
When the people, they know they having tuberculosis, they scared. They has to scare. They has to take care, take your medicine, take it, whatever the doctors say, and whatever the clinic say they have to do, and also finish the treatment because it's more important, that one.
Though it is a very communicable and contagious disease, but we have a medicine that's the great achievement of 21st century, I think, and we can treat TB, and if we get a treatment timely, we will not go to die just because suffering from TB.
I just decided to share my story because at first I felt like this was going to be such a hard thing to go through, but after I went through it, it was painless, it was easy, and I just want the next person to be able to go through it as easy as I was.
I share my story with this project because I want to know the people how important is they understand what's the TB, what's the TB doing in your life, in your body, if you don't take care, because it's happened with me, but the TB is curable.
I think that if I share my experience about latent TB disease, definitely someone will be benefited and they will be get rid of TB. That's only the reason I want to share my experience about latent TB, because I want to educate the people through my story. If someone is benefited through my story, it would be, I think that would be my achievement.
One message I would share about tuberculosis is that it's a big word, a big disease, which is curable, and that you shouldn't be scared of it because it is curable, and that you can get through it, and there's a lot of help out there that will get you through it.
I would like to request you all, please come together to fight against the TB disease, and we can get through our TB-free world. So this, everybody must have this dream, and I have this dream. Can you come together to fight against TB disease and make a world free of TB?
Were those fantastic patients or what? Tree, Santos, and Deo gave of their time, and they really shared their hearts to share with us about their disease or their infection and the process that they went through for their treatment. I also want to thank the leads for this project, Ann Lanner and Nicole Richardson-Smith, along with their team leader, Marie Frere Sessions, for all their work on putting this together. This is an ongoing project. We will have multiple videos, we will have multiple stories. And so any of you who are listening, we would like for your help in identifying additional patients who would be willing to tell their stories. We are going to be doing additional edits to the video and also developing other videos, and we're going to be showing these and getting feedback from people in the field. I've included Ann Lanner and Nicole Richardson Smith name up here and their contact information. We would welcome your input for others who can share their stories. Thank you very much.
Thank you, Wanda. I very much appreciate it. Also, a secret that Ann and Nicole can share with you is that they witnessed me wearing makeup for the session I had. So I broke with grooming standards of the Public Health Service. But it was fun. So let me, Susan, I don't see your slides here. Oh, okay, thanks. Let me introduce our keynote presenter. It's a real pleasure to invite Dr. Susan Ray, a friend and colleague. Susan is a professor of medicine in the Division of Infectious Diseases at Emory University School of Medicine. Her academic and clinical pursuits are centered on the epidemiology, prevention, and treatment of infectious diseases affecting the urban indigent minority populations served by the Grady Health System. She's a hospital epidemiologist for Grady Health System. Dr. Ray has been a clinician at the Fulton County TB Clinic since 1999 and became the medical consultant for the Georgia Department of Public Health TB program in 2010. Susan's specific areas of interest include the management of co-infection with HIV and tuberculosis, clinical trials of therapy for tuberculosis infection and disease, defining the immune response to Mycobacterium tuberculosis infection, the molecular epidemiology of tuberculosis, hospital and molecular epidemiology, prevention of healthcare worker exposure to blood-borne pathogens, prevention of healthcare worker associated infections, and the epidemiology and treatment of community-acquired methicillin-resistant Staph aureus, better known to us as MRSA. Dr. Ray is the founder and physician director of the Woodruff Health Sciences Center Needle Stick Prevention Center. She has been an investigator with the Georgia Emerging Infectious Diseases Program since 1998 and is currently the lead Georgia EIP investigator for healthcare-associated infections and invasive MRSA projects. Dr. Ray has also served as a member of the Emory Institutional Review Board since 2003, and the spirit of no good deed goes unpunished. In 2006, she was appointed as vice chair to the IRB. During the years 2003 to 2010, Susan served as the principal investigator for the Emory Atlanta site of the CDC-sponsored TB Trials Consortium to carry out investigator-initiated clinical trials of the treatment for latent TB infection and disease. Susan is a native of Atlanta, attended the Cobb County Public Schools. She completed her undergraduate degree studies at Duke University in biomedical engineering as an AB Duke scholar, then returned to Georgia and attended Emory for medical school as a Woodruff Fellow, as well as for the remainder of her training in internal medicine and infectious diseases. Susan, who I've known for many years, and her partner have two children, ages 13 and 15, where this time goes. And are active public school and church volunteers. Dr. Ray is a classically trained soprano and continues to perform as a soloist with her choir and in church musical theater productions. So please join me in giving Susan a warm welcome to CEC. Thank you.
Thanks, everybody. I'm really honored to have the chance to speak today and kind of nervous about it, but let's move on. So 3 years ago, as Dr. Castro just said, I had the good fortune to begin working as the medical consultant to the state TB program here in Georgia. And these are the dynamic and committed people there that I have the pleasure of working with. And in the center of this picture is Dr. Rose Salas, who's the beloved director of the Georgia TB program. And she's been with the TB program for many years and became the director about 2 years ago, I think. And we're going to come back to this nice group of people at the end of the talk, and I'll tell you more about some of them. My own interest in TB began very early in my career, even before finishing medical school. At that time, in the mid-1980s, I'm very old, the resurgence in TB had not yet been recognized, even though it was happening. We just didn't know it. And I was really kind of concerned that TB might just disappear, and I wouldn't get to see anybody who had TB because, you know, it was very rare. And I was sort of sad about that. But by the time I began my ID fellowship, the TB epidemic was in full swing, and the epicenter in our state was Grady, which is pictured here. And that's where I spent much of my clinical time and where I am based now. Well, during the years of training, I gained a wealth of knowledge about how to diagnose TB involving all parts of the body, and in particular, how to diagnose and recognize TB in persons who are immunocompromised by HIV infection. I also learned firsthand how unrecognized TB in a hospitalized patient can lead to a very big and bad TB outbreak. My TB mentor, Dr. Henry Blumberg, pictured here in his youth, became a leading expert on preventing the nosocomial transmission of TB, and I am one of his many disciples. But for all that I learned, I really at that point knew very little about what happened to TB patients once they left the hospital. And pictured right across the street from Grady is the place that they would go. Right there, Fulton County Health Department. And 13 years ago, I began my education and work in public health in TB by working in the TB clinic there, right across the street. So in that clinic with these great people, I've learned what happens after the diagnosis, how people with TB are treated, how they get better, and how many things are really big obstacles along the way. Now, the TB epidemic in Fulton County is fueled by homelessness, substance abuse, mental illness, incarceration, poverty, and HIV co-infection, and is really centered largely on people who were born and raised in this community. In 2012, almost 1/4 of all the TB cases in Fulton County were HIV co-infected. That's a startling statistic. The African American community, in particular in metropolitan Atlanta, is disproportionately affected by all of the problems that I mentioned above. And several years ago, the local, state, and federal agencies, including CDC, worked together to come up with a program for Fulton County that they thought would improve the treatment completion rates for high-risk contacts of TB cases. They had been working very hard on completion rates for the cases themselves, but had a poor, very poor track record for getting the contacts to cases to complete their INH therapy. So previous clients of the TB program who had either been active cases or a contact with latent TB infection and had themselves successfully completed treatment were recruited to act as peer counselors within their community to better approach and educate people that were exposed to active TB but who weren't willing to adhere to the treatment recommendations. And this program was to get people living within the community to support the goal to eliminate and reduce TB by gaining access to clients that were reluctant to give a listening ear to the local public health workers. Pictured here is Ruby Hardy in the center, who's been at the head of the TB program in Fulton County for as long as I am aware, as long as I've been there. She's a very strong and dedicated leader. This is Dr. Yamin, who is the staff physician in the TB clinic, and I've really enjoyed working with her for about, I think, 7 or 8 years now. And Dr. Omar Muhammad, is the quality control clinician physician there, and he is the person who recognizes that I've forgotten to write some part of my recommendations out or click a box. And he's also a great consultant when I'm looking at chest x-rays. In the back there is Ben Yarn, and Ben works with the DOT workers and the field workers, and has been really helpful to me in getting special care for some of the patients that I take care of where they need special support. And he's the person I called to interview Rita. So Rita Hickson was identified as an ideal candidate for a peer counselor, and she was hired as one of the first peer counselors in Fulton County several years ago. She was trained by the county staff and then began working 20 hours a week, managing her own group of clients from her own community who had latent TB infection. Her counseling and support made a great impact, and her clients had very high completion rates for their LTBI therapy. Ms. Hickson has since been hired as a disease investigator with Fulton County and serves as the housing liaison for homeless suspects and cases of TB. Last week, Ben interviewed Rita for me, and she had these things to say. The most rewarding part of my job is knowing that I'm helping others going through what my family and I had experienced, knowing that I am not only reducing TB in my community, but also helping others in their community. It's a good thing to see people go from being sick to doing better and knowing that I had a part in it. The most challenging part of my job is educating clients with substance abuse about the importance of treatment adherence. Unfortunately, TB treatment is not their priority. It's also hard to convince clients who don't believe that they have TB infection to get tested and to be evaluated. And I think the most important way to prevent TB disease is to continue to educate and bring more awareness about the disease and the transmission. Awareness and education is the only way to get people tested and evaluated. And I've really enjoyed working with Rita over the last 10 or 15 years in clinic. She's a remarkable young woman. Now, DeKalb County is contiguous with Fulton County, but worlds away, literally, when it comes to describing TB in their community. At least one of the patients that was interviewed in Wanda's film is from DeKalb County. DeKalb County accounts for the largest number of refugee resettlements in the southeastern United States. A total of 2,555 refugees were evaluated in DeKalb County in 2012. And as you probably know, TB is a required element of the screening process for refugees. And so the TB program is in a position to provide TB services to a large number of suspects with TB and latent TB clients that are identified in the refugee population. In 2012, they identified a total of 123 suspects from outside agencies, and in the refugee clinic itself, they found 300 Class B suspects. After evaluating everybody and sorting them all out, they found a total of 78 cases of active TB in their county for 2012, and that was the highest of any Georgia county. Now, among these cases, 76% were foreign-born, 14% were pediatric, and 9% had prior active TB. This pie chart shows the country of origin frequency for the foreign-born TB patients. And the distribution there is somewhat different from that of the entire United States. In DeKalb County, Ethiopia is number 1, followed by India, Mexico, Bhutan, and Burma. There's 14 other countries represented as well in the other part of the pie. So this is a county where the challenges of TB control are legion. They have to have an untold number of translators to even evaluate, whether somebody's sick or not. They have to deal with all the cultural differences from these many different communities. And they're starting with a population that is much more likely to have been exposed to TB and infected with TB than people that are born here. And it can be very difficult to discern whether active disease is present. And this is a place where you become convinced very quickly that we need better ways to diagnose active TB and to distinguish it from latent TB. This is Dr. Oladelli, who was referred to in the video several times. He's been at DeKalb County Board of Health for a long time, and he's a very dynamic and busy guy. And I've enjoyed working with him over the years. I want to say, in particular, before moving to some other parts of the state, that Fulton and DeKalb TB programs have been very helpful in supporting TB research, and they have participated in the tuberculosis clinical trials, the TBTC, and in the past at Fulton and DeKalb. Presently, DeKalb County is still participating in the Tuberculosis Epidemiologic Studies Consortium. They've launched a really big study of the difference between tuberculin skin testing and QuantiFERON and what those results mean over time. And then at Fulton County, we still have immunology studies that are carried out in collaboration with one of my science colleagues at Emory. So here's a map of the public health districts in Georgia, and we've been talking about places in here. I'm not sure, here. Places in here, but I'm going to take you to some other places around the state. I asked the TB coordinators from around the state to send me stories of workers in their districts and counties who'd done a good job, done something hard, done something unique that I could talk about today. And they were very generous and very quick in responding, and I'm going to go through some of those. Kay Smith is the TB coordinator for District 1 in Northwest Georgia, and this is the view out her back door at work. It's pretty good, isn't it? But don't let the idyllic scenery fool you. There's plenty of TB business in this heavenly corner of Georgia. And Kay provided me with several examples of great public health workers in action, and I couldn't use everything that I got, and this is one that I picked. So Tim Kirby, this is Kay speaking, or her writing. Tim Kirby has had a very challenging year in TB control for Gordon County. His dedication and perseverance have rewarded our program by limiting the number of active cases spread throughout the county. One of his most recent contributions was his work with an active case who had refused hospitalization upon initial suspicion at the emergency room, who would then not reveal their contacts, and who lived in a close-knit neighborhood in which there was a lot of movement throughout neighbors' homes by children and adult friends. After gathering information about 38 contacts from the patient's wife, it took much perseverance on Tim's part to round up all the neighbors onto one neighbor's deck and do a skin test on everybody who was involved, and then to serve as marriage counselor for angry spouses after learning about the exposure and the social visits that had happened that they weren't aware of, and then to complete the contact investigation while some contacts were now located in jail or prison. And it was also Tim's diligence that resulted in the successful treatment of an 18-month-old toddler who was a contact and a clinical case from this group. He had to try 20 different concoctions of Slurpee, yogurt, pudding, and finally the successful Karo syrup mixed with chocolate. in order to get the toddler to take treatment. And he said that Karo syrup only worked because the toddler could not spit it out, although the toddler tried. As a result of the relationship that Tim developed with the wife, I don't think the patient ever liked him, and other family members, both active cases were treated successfully, as were all the identified LTBI patients. Additionally, the 18-month-old began to grow and gain weight and no longer appears as a failure to thrive. And while he used to be a quiet and reserved child, they've now realized that his true personality is to be quite active, and as his grandmother says, he is all boy. Tim genuinely cares about his patients, develops a relationship of trust and concern with them. His efforts are exhibited by spearheading a Christmas gift drive at his health department for needy families. He purchased groceries and treats for less fortunate patients and marshaled resources together to provide for large tangible needs, such as getting a bed for one family. TB treatment at the Gordon County Health Department is not soon forgotten, as Tim Kirby makes a lasting impression on his patients, so much so that they still drop by just to say hi or to walk by his house to wave a friendly hello. So I thought that was a wonderful story with some really good details, and lets you know what's happening out there in the far reaches of our state. Now, this is a story from the center of our state, sort of the area near Macon, if you're familiar with that. And it was submitted by Christine Sykes, who's the nurse manager of the Houston County Health Department. And she said she wanted to acknowledge the outstanding work performed by Kathleen Summers, who worked in collaboration with the North Central Health District TB program to care for a patient diagnosed with TB during 2012. But it was a very complex case. It was complicated by the fact that the case investigation involved a public university that was across county lines, an entire nursing home facility, temporary homelessness, interstate travel, and ultimately an uncooperative landlord. Kathleen had to collaborate with the university administration to communicate the importance of testing all the classroom and work contacts. She arranged for testing in return for the reading herself on campus. Then she ensured communication with the neighbor county health department, the campus health program, and the students. And then the students left campus for Christmas. So Kathleen had to communicate with the health departments all across the state of Georgia to get their skin tests read. The contest investigation also required testing all the residents and the employees of a nursing home facility where the case had worked. She facilitated all that communication, testing, and the readings that were done. She provided education to the nursing home staff and the employees. But during this whole time, the patient herself was without a support system. She was not, as the patients that we saw in the video described, she had to drop out of school. She couldn't attend her job, and she didn't have a way to take care of herself. And she was in isolation and not able to even go to the grocery store. Kathleen and the North Central Health District TB coordinator got gift cards for her, and they went to the grocery store for her. Local churches were called, donations were given to assist in the rent, and the landlord illegally evicted the patient, Kathleen contacted the American Lung Association to provide housing assistance. The district coordinator checked on her frequently because the patient was alone in an unfamiliar city in a hotel room with a door that led directly to the outside, which can feel kind of scary if you're a young woman in a strange place. And Kim would go visit her. I'll show you her picture in a minute. She would stop by and help the patient clean the hotel room while they talked. And then the patient was allowed to go back to the prior living arrangement, but then the landlord became hostile and said, you can't have DOT here. So they had to find another DOT site. The patient was able to travel home for Christmas, but required some special dispensation from the local district, the district pulmonologist. And Kathleen worked with the patient closely to ensure no interruption in treatment and allow the patient the benefit of the emotional support of visiting her family over the holidays. So Kathleen's passion for TB, professional and compassionate care of patients, and the depth of the knowledge of the TB program were displayed in every aspect of her care for this patient. And although this story highlights the cooperation and collaboration that occurred within the district, the county, the state, and the community, this patient is only one example of the kind of work that goes on each and every day in that part of the state. Now, this is a sort of fun field trip that one of the districts got to make. in May of this year, and Janice Maxwell, who's the coordinator for the Coastal District, submitted the following account of some field work they did. So on May the 30th, 4 Chatham County Health Department nurses and a district DP coordinator, and that's Janice right there, boarded a shipping vessel to screen 21 crew members exposed to an active TB case who had disembarked the ship at a foreign port. No one, and I mean no one, Customs, Border Patrol, Coast Guard, shipping agent, nobody was going to be allowed to get on the ship until the health department had screened the crew members for TB. And the crew members were all wearing masks, as if they all might be sick. So they marched up the loading ramp, got logged in. Here's the ship, it was huge. Here's the guy logging them in. And then they proceeded to interview the crew members who spoke no English. So the ship captain did speak some English, and he served as the interpreter. Here's one of the crew members wearing a mask, bringing them a chair. They performed T-spots, symptom screens, and HIV testing on all the crew members, and they got, nobody had any signs or symptoms of a disease. The 20 T-spots were drawn and later returned negative. And one of the crewmen had an indeterminate T-spot result, and the ship had to leave port, and they didn't have time to repeat the T-spot, so they sent him to the local hospital. They drove him there for a chest x-ray just to make sure that was normal, and brought him back by 9 o'clock at night. So they started all this at 6 a.m. As soon as the radiology report was obtained, the agencies were all notified, and the ship cast off and prepared to disembark. It was allowed to leave the port heading to Venezuela, and 9 of the crew members would need to be retested in 8 weeks, wherever the heck they were. So that was a big adventure for them, and they really seemed to enjoy it. I had like 4 different people send me the same story, and it looks like a lot of fun, but also required a lot of flexibility and good humor and an entire day for 5 people. And you can imagine, what happens at the health department when 5 people are gone. I'm not, I don't know what happened. I guess maybe they put a sign up, said come back tomorrow. So here's another story of some more trouble in central Georgia. And this is what happens when you have a place where there's not very many cases of TB and then one happens. So in July of 2012, the Jasper County Health Department was notified of a new case of TB. But that's a small county, and it's staffed by only 1 registered nurse. And she was all but overwhelmed by this problem. The patient lived 20 miles away from the health department. And the way they have things set up, she was supposed to provide the DOT every day. The patient didn't have a way to get there. She was going to drive. So she would have to do 40 miles round trip for daily DOT. And then in the process of doing a contact investigation, found a suspect, so a second person who needed DOT, who lived a further 18 miles away. And I think she just was going to just quit. So Wayne Allen came to the rescue. He's a communicable disease specialist that had been assigned to the Jasper County Health Department, and he said, I'll do DOT 3 days a week. And then Kim Warren, the district coordinator, and Ronnie Boone, the district infectious disease supervisor, who are located in Macon, said they would do the other 2 days. And that was a good plan. And then it was discovered that he needed frequent phlebotomy because he also had liver cancer and hepatitis C. And his liver was reacting to the medication or to his underlying problems. It was not clear. And the strategy was just to check liver tests frequently to make sure that things didn't get out of hand. And so this man said, well, I'll do the phlebotomy as well. And he did twice-a-week phlebotomy. So in early September, the nurse transferred to another district. I think she was really not happy to be there anymore. And so the communicable disease specialist, Wayne Allen, and the supervisor, Ronnie Boone, just took over entirely and managed the case, did the daily DOT, the sputum collection, the blood collection. And the RN case was, the RN position was filled in November, but the TB management, case management is still being done by the people pictured here, or it was until he finished care, which I think was very recently. So this story demonstrates the collaborative teamwork between the district infectious disease unit, health department people, and a communicable disease specialist who really just stepped up and said, that looks hard and I think I'd like to help out. It was not something he was expected to do. This is a picture of the TB team at the Cobb Douglas Public Health Department, District 3-1, and the leader of this team, the coordinator, is Philistine Gardner. She's a very dynamic individual, and I've worked with her closely, along with Dr. Alvarez, on several complicated cases over the last few years. And Philistine's style is really notable for how much she extends herself personally to take care of patients. She's extremely empathetic and very concerned about their circumstances when they're diagnosed and sent home from the hospital. And she says when our patients are released from the hospital just before the weekend, they're still weak, they have no family support, so my staff and I take turns visiting and preparing meals over the weekend. So she cooks for people. Once a family didn't have food and there were no funds, so our team brought grocery, we put money together and paid for other medications. And she said that she's been told by families that they felt that they would have died had the staff of the health department not intervened. The husband of a patient expressed that he was about to give up because the burden of trying to care for his wife and address the needs of his home was overwhelming, and he thanked God that he met us. And a patient's father stated that the compassion and dedication his family received made it easier to accept and handle the responsibility of having a child with multidrug-resistant TB. And this father cried at the relief that he felt from their support. So they do a tremendous job helping the families in their district. This is a person I wanted to say a lot about, Millie Reeves, pictured here in the middle of this group. Millie Reeves is the statewide TB program coordinator for the Georgia Department of Corrections. And I've gotten to know Millie over the last few years and really have an immense respect for her ability to diagnose and treat TB cases that are very complicated in men who are in the prison system. And I asked Millie to tell me some things about what she's learned in her career in TB, and she sent me a very long and interesting letter. And I won't read all of it, but she said, everything I know about TB I learned from public health. I started working at the prison in 1983. It was called Augusta Correctional and Medical Institution, or the ACMI at that time. In mid-1986, the MD that was treating patients couldn't take it anymore and left for greener pastures. So they asked her to continue seeing patients. I had no idea about treating TB other than my work with the MD prior to his leaving. She got a lot of great advice and teaching from several doctors over the years, including Dr. Korp, Dr. Liang, and Dr. Vosio, and Dr. Martins. The clerks in Rome from Batty helped train her and were a tremendous asset in providing information about old cases and treatment for LTBI. And she's worked with many dedicated nurses in the state office and in the district and local health departments. The TB program has helped provide training to countless nurses in the prison system. The corrections work group was able to provide educational programs for doctors, security, and others involved in the care and custody of inmates in the prison systems and jails. This same work group has tried to engage in a dialogue with the county and city jails, which do not fall under the Department of Correction. And this currently remains our biggest challenge, since each of these facilities is controlled by the sheriff in that county and there's no unified approach to TB control. Some jails still don't routinely give or read PPDs, and inmates from these facilities come into the prison system each week to our intake centers or get released back into the community. She says, I feel if we were able to get all the jails moving in a unified approach to TB control, the state would benefit tremendously. There are many missed opportunities for case and LTBI detection in the jails, such as was seen in the recent outbreak at the Chatham County Jail, which was something that CDC came and helped us with an EpiAid. So she's passionate about what needs to be done to improve the control of TB in correctional settings, and I've listened to her and joined forces with her to try to make that clear. Now, I want to just tell you one old story. It's something that's not current. On October of 1996, there was a 6-week ultrasound done of a first pregnancy in a 34-year-old physician, and that was me. And there's a cute little peanut. I was extremely happy. I had wanted to be a mother for my whole life and was starting at the ripe old age of 34 and was really excited to finally be getting to pursue something I had wanted so much. I was very happy. 2 weeks later, well, I had been feeling sick, and when I really realized it, I'd been sick for like 8 days with a fever, and decided I never want to call the doctor. Never, never. But I decided I should since I was pregnant. And the obstetrician said, well, do you have a cough, congestion, sore throat, dysuria, diarrhea? No. But, I was feeling kind of like bad from being pregnant, and she wanted to know what I meant by that. I said, well, when you're pregnant, like they tell you, you're going to feel a little bad. I can't eat very much. I get short of breath, and I've lost 5 to 10 pounds. And she said, that's not normal for pregnancy. And she asked me about some of my prior tests, and we reviewed those. I had already had a CMV antibody that was positive, which is cytomegalovirus, a bad thing that you don't want to get while you're pregnant. I'd already had it. And my PPD test had been done 6 months before it was negative. She said, well, go get another PPD. You do work at Grady, and get toxin plasma serology and get some other labs. Well, the PPD was 25 millimeters. Hank Blumberg read it, and I am thankful that he didn't scream in horror. I think he probably went in another room and screamed in horror after he calmly read my PPD and said, why don't you go get a chest x-ray? And I had a huge left pleural effusion. The stomach bubble was being displaced inferiorly because my diaphragm was turned inside out by the pressure of the big pleural fluid, and that's probably why I couldn't eat very much. I was quickly seen by a pulmonologist who did a pleural biopsy and thoracentesis, and 2 liters of fluid were obtained for diagnostic studies, and also a biopsy. Now, at that time, Bev Metchok, who's here, is my good friend, was still the clinical microbiologist working within the Emory-affiliated hospitals, and Grady in particular. And she happened to be around in the right place at the right time and picked up the pleural fluid, a 2-liter bag, and drove it over to Grady to someone else that you all may know, Dave Lonsway. He was the clinical microbiology lab supervisor at Grady at the time. And in those days, over 150 cases of TB were diagnosed annually at Grady, and there was great expertise in mycobacteriology. And David volunteered to carry out the microbiology testing on the pleural fluid. And I'm not really sure who volunteered what first. It may have been Bev, it may have been David, but they commandeered the testing and didn't want somebody else doing it. Now, as you're likely aware, it's very important to confirm a TB diagnosis with a positive culture so that you'll know what you're doing. As you may not be aware, it's extremely hard to do that with pleural TB. Having pleural TB is sort of like having a giant PPD, and what you mostly have is a big immune response to a very tiny bit of tubercle bacilli, and it's very hard to recover them. And the chance that you can actually get a culture to grow is pretty low. But since I was pregnant, it was really important that we knew exactly what we were doing. So the 2-liter bag of fluid was dropped off by Bev to Dave at the Grady lab. And he knew that the highest yield for culturing a fluid is if you culture all of it. But how do you culture a 2-liter bag of fluid? And what most microbiology labs would do if they got 2 liters of a fluid is decant 50 cc's into a test tube and throw the rest in the trash. And when I found that out as an intern, I almost cried. You're going to throw it away? Yes, they're going to throw it away. Well, he did not throw it away. He spent 2 hours decanting 50 cc's at a time, centrifuging it down. He had to do it like 40 times to get all the fluid into one sediment that could be cultured. And his work is the reason that we had a positive culture. So the pleural fluid was exudative and lymphocytic. The biopsy was, they missed, it's a blind biopsy. It looked normal. It didn't grow anything. And the pleural fluid grew MTB. Thanks to Dave Lonsway, we recovered it, and it was sensitive. Now, I was about the worst patient that you can imagine. I would not be featured on one of these videos. I was unhappy. I was uncooperative. My side hurt. I was afraid my baby was going to be hurt by the TB medicine. I didn't want to provide sputum samples. Hank Blumberg had to call me up and come over to my house and get me to cough in a cup. I thought it was ridiculous that they wanted sputum samples from me. I said, I have pleural TB. I'm not infectious. Leave me alone. I didn't want the health department to do skin testing on my family. I refused DOT. I got my medicine from the local pharmacy, and I was irate with the local pharmacist when they said they didn't have a month's supply of ethambutol on hand. I didn't attend an extended family gathering at Thanksgiving that year, and it was partly because I was so depressed and partly because I was pretty sure that they were afraid of me. And I think they were. We were sort of both right. It was an awful time. I was extremely depressed. I sat, when I went back to work, I just sat at my desk every day and played Minesweeper. Y'all remember that? It was a really bad time. And the person who was my TB outreach worker was not really an outreach worker. It was the nurse at the county health department. And I didn't meet her during that whole time because I wasn't going to go there. And I wasn't going to let anybody come to my house either. She was a voice on the phone, Francine Greiner. She was kind, but she was firm. She called me just often enough not to make me really mad. And she handled me while avoiding conflict. And she never once told me that I was being absolutely ridiculous, which I was. And she gets a gold star for that. Now, this is her now, and she has tried to retire from DeKalb County Health Department about 3 times. I think she was the district coordinator at that time, but she's now working part-time in the refugee clinic, and she was in the middle of a storm of people in native costumes from around the world and speaking all kinds of languages and asking about housing for somebody and a urologist for another one when I stopped by there yesterday to get her picture. And I'm very grateful to her patience and wisdom. She knew how much to try to get me to do and how much to just let it go. And I've learned that all the wise TB control people around the state get that. There are times when you follow the rule book, and there are times when you put the rule book down and you say, well, what really matters here? What's the big picture? And that's what she did. And I credit her with that. And so the most common outcome after TB in pregnancy, which is a pretty common thing around the world actually, is a healthy baby. And there's my healthy baby a few weeks after she was born. So why do I tell this story? I'm reluctant to tell it, not because I'm shy, I'm clearly not shy, but because it's misleading in some ways. It's completely atypical. I'm female, I'm white, I'm privileged, I have great social support. I wasn't even a contagious case of TB. But the illness brought out the worst in me ever. I mean, I was really hard to be around. And I found it very hard to handle emotionally, despite my education and my background. And so just imagine how much harder it is for a person who doesn't have all these good prognostic indicators. And that's what I want to tell you about, and the reason I wanted to tell you, because if it can have such an impact on somebody who really should have been able to handle it better, just imagine if you didn't have all those advantages. So let's get back to the present, and here's the dynamic team at the State Health Department. And I want to talk in particular about this guy right here, and this woman back here. Dave Maggio has been the epidemiologist at the Georgia TB program for almost 3 years. And he quickly recognized that the genotyping data that we were getting was really valuable. But he also recognized it wasn't going to matter very much if we didn't get complete genotyping data, if we were missing links to examine. And so he began to pursue getting the isolates of TB from cases that were still out there, still saved somewhere in a freezer or a microlab. And although he came to work in the middle of 2010, I think, he was still able to go back and get isolates from the end of 2009 and the beginning and all of 2010. And in 2012, he's been able to get 100% of the isolates submitted for genotyping. And that's really impressive. And I call this the Maggio effect. He's sort of like the Energizer Bunny. He's about as energetic as he looks in this picture. The other thing that I credit Dave Maggio with is how enthusiastic he's been about communicating the genotyping data. He understands that the people who can tell us what the genotyping data means are the people who know the cases. And the de-identified information sent in centrally is not going to tell the narrative and the story that will help you figure out the connections between people. And he knows that if we can communicate the genotyping data out to the local health departments, that the staff there can begin to put things together and figure out maybe some chains of transmission that had not been apparent. And so he does this with great regularity and enthusiasm, and he's a great teacher. He spends lots of time explaining what the genotyping is and to understand how they can draw conclusions or not from the information. And this is a picture of an epidemic curve that's a genotype that's very common in the state, but particularly common in DeKalb County. And based on this finding, they've been focusing some attention on what to do about this particular community in DeKalb County and how to impact the TB there. And Jatu put together a World TB Day event that will be ending soon. And I hope the weather was good enough for people to come out. But it's a community health fair that they put together as a result of the molecular data that made them think that this is where the problem was. Jatu is a tremendous social worker at the state level. At first I thought it seemed a little silly to have a social worker in the central office because it just didn't seem like she could really reach in a very direct way people in the local communities, but she's been very effective. And unfortunately, we don't have enough money for a social worker in every county or every district, which was what would be really great. So I'd like to just end with two things and tell you what the public health mantras for TB are, in my opinion. One is that a single person can make all the difference. And TB disease is spread by people who haven't been diagnosed. And if you don't look for it, you won't find it. And that everybody with TB wants to feel better. And it really helps to remember that when you're dealing with a difficult patient, like me. And what will it take to eliminate TB? Dr. Castro tells me I need to think about eliminating TB and not just reducing it. And so in the short term, I think we need to use the knowledge that we already have to address the congregate settings where TB transmission continues. In our own country, that's in jails and shelters. And across the world, that's in hospitals, jails, refugee camps, slums. It's not rocket science. It just takes commitment and shoe leather epidemiology and a lot of people on the ground committed to intervening where we know we can make a difference. In the near term, it would be really great if we could sharpen our focus for identifying latent TB infection in a really accurate way, and also identify who is really at risk among those with latent TB for developing active TB. And that really means we need some kind of an immune marker or a biomarker. And of course, we need to simplify and shorten our treatment regimens for people who are ill. We've done that already for latent TB. It's pretty amazing, the rifapentine regimen. And in the long term, of course, we need a vaccine. And that would just handle everything. So thank you to my colleagues at the state. In particular, I want to thank Dave Maggio and Rose Salas, who helped me get the information together to put in these slides. And I think I even plagiarized some of what Dave had done earlier this week. And I appreciate the time.
Thank you, Dr. Ray. This is a really fantastic overview and a very poignant personal account of what's happening in the state and to you. Thanks for your bravery and valor for doing what I personally think we really need more of. The speaking out and letting persons know that TB is still very much with us is almost a necessary ingredient if we're going to not lose this battle against this disease. What I want to do now is use the time to invite any of you here or on the telephone to ask comments, open season on the presenters, or provide any questions or comments are welcome. If you're seated in the orchestra seats, there's a black little gadget that you press on or you mash on if you happen to be from Georgia, and there's a green light that comes on. Otherwise, go to the microphones on the sides, please. But we welcome any observations you want to share with us.
This is for Dr. A. One, I wanted to thank you. I thought that was great, really it's all about people instead of a lot of the statistics, and I think that was very helpful. One of the things, it is about people, and at CDC I know we're struggling within programs, across programs, with looking all the federal funding cuts, state funding cuts, don't even know a lot of what's happening at the county level. Are you close enough to the program to advise us, or what are the strategies? I know it's so difficult, but you really portrayed lots of people. This is very people dependent, and so that's a big investment. So is there any pearls that you could share with us on how we might approach this?
I'm afraid I don't have any magic answers. I'm looking back there for Dr. Salas to see if she might want to weigh in on how things are done at the state level. I almost included one of the web pages from one of the counties that clearly they designed several years ago, and it has a list of all their staff members, but about half of them are vacant. It just says vacant, vacant, vacant. So they're not fully staffed, and I think their staffing will go down. And I think their strategy is, I think they're all missionaries. They have, I think most people in public health are. They're willing to do more than the job description says for less money than the contract said they would get, and they help each other. And they really come together across counties and districts. When one district has a problem, a lot of other people will go over that way and help them. Rose?
Rose, would you mind please walking down to the microphone? I think down or...
Down.
Right. While she comes, this is the small giant of the Georgia TV program, Rose Sales.
Most of our federal cooperative agreement funds goes to personnel. Most of them, a lot of them goes to state TV program staff, the people that you saw in the picture. DeKalb and Fulton County get a lot of personnel funding from federal cooperative agreement funds. All of the outreach workers, for example, in DeKalb are federally funded, and a lot of communicable disease specialists in Fulton are federally funded. And because 56% of our cases are from Metro Atlanta, most of our support goes to Metro Atlanta. So, but we do have funding to other counties like Chatham and Cobb and other districts that need. But over the past few years, we've known that because county health departments, they have lost a lot of staff from staff that are funded, that used to be funded by county boards of health. They've lost that. And so whenever they have a problem like a big outbreak investigation, in Augusta, for example, they have 13 counties. They would get nurses and DOT workers and other staff from different counties to help one county, Richmond County, for example, when there was an outbreak investigation. But we just, we're embarking on program reviews of our high morbidity counties this year. And when we looked at DeKalb County, which we did recently with Dr. Christine Ho was able to help us, we do know that there is a lot of need in terms of staffing. For example, Dr. Oladela, who was mentioned in the video, he says that latent TB the refugees in contacts with latent TB infection, they don't have enough staff to follow them up, so they go into a sort of a black hole. It's very difficult for them to follow up. There are not enough people to do that. But we've been able to support them with 2 part-time LTBI nurses because of some supplementary fund that we got from the state legislature last year. And all of those people in the video were peer counselors, our peer counselors in Gwinnett and DeKalb. And we were able to fund that through state legislative funding for those peer educators, and they were able to extend that funding for the next year. So they were at the Senate and the House actually just met last week, and we thought they would pull that funding, but we were able to advocate for them to continue.
Thanks, Rose. Any other questions or comments? I don't know if there's anyone on the telephone line. So I'm pausing to give them a chance. There's a negative motion in the back. Okay. So what I'd like to do is to close by sharing with you, this is a slide that I'm showing here. I was fortunate to get invited to be part of congressional briefings that took place in Washington, D.C. over the last couple of days. And the American Thoracic Society, as well as the Congressional TB Caucus, convened a briefing the day before yesterday, and yesterday there was a Senate briefing sponsored by Senator Brown with more of a global aspect to it. And I shared this as my perception of some of the remaining challenges and needs. It very much resonates with the question, John, that you asked of Susan. You know, this is a very labor-intensive process, and a big challenge that we face is the perception that Affordable Care Act is going to be the panacea. And those of us who've been around long enough are seeing that we're teetering on the verge of disaster by accepting a potentially faulty premise. Even if everyone were to be properly covered by insurance so they could go to neighborhood health centers or anywhere else, as you can see from the various stories that Susan laid out, you really need the workers out there. I think we need more social workers than anything else, given who's getting TB. You know, it's interesting to observe. I mean, I continue to work at the Grady Infectious Disease Clinic, and I think the most important person in our team is a social worker helping navigate the insanity of being on an ADAP program or things like that. So the same thing is holding true, especially when you see the vulnerable populations. The other thing is that I wanted to share with you the lower slide. That said, you know, as I said, TB preys on the poor, but it can affect anyone. In the lower left-hand side, the people here spoke. This is Mildred Fernando, who I'm showing here. She's from the Philippines, and she told the story of a decade with tuberculosis, which started at the age of 17. She apparently had drug-resistant TB that was never recognized, and she had multiple bouts of TB, and then she shows a photograph of her celebrating her 27th birthday while under treatment for XDR-TB. Darlene Van Delft and her husband are both physicians from South Africa, and many of you have heard her story about her bout with XDR-TB, and she actually had a chance to speak. Andre is from Namibia. He also spoke about his story. Pat is a nurse from South Africa. Actually, both Mildred and Pat are deaf because of the second-line injectables. Darlene chose to forego some of the injectables. She was lucky enough to get access to compassionate use of bedaquiline at that time. And I don't know, for those of you who have not been following the story, so of course, shown in black and white, First Lady, President Nelson Mandela, Desmond Tutu, and the latest Pope is missing part of his lung because of tuberculosis. I'm planning to take full advantage of this as a person who's trained by Jesuits, and I've already reached out to Mario Raviglione and asked him if we can get the Pope to speak on behalf of both the poor and tuberculosis. I'd like to close this in time by acknowledging that while we get together to commemorate the date when Robert Koch announced the discovery of the tubercle bacillus,
My personal goal is that we no longer commemorate TB on this date, but we come up with a new date when we can celebrate the demise of this bacillus and the date when it was eliminated from the world. And obviously, all of you seated in this room are very much part of that work, and it's work and a goal not yet achieved. So the progress that we are making is all this labor-intensive effort, but it needs to be sustained over time, and we are now at the very peril of being part of one of the most successful programs in health departments throughout the nation. And this propensity to think that the TB problem has been solved, attention can be shifted elsewhere. For those of you who are interested, you may want to take a look at a blog editorial written by Lee Reisman, who in very characteristic Lee Reisman terms talks about the U-shaped wave of concern and about the risk that we now face as a nation as TB rates are at historic low. So I want to reiterate my thanks to Terry, Wanda for the excellent work at trying to put faces of tuberculosis and use these voices to convince others. Dr. Susan Ray for a really outstanding keynote presentation about what it takes in Georgia, for the valor of telling us about your personal story, and to all of you. And we're closing 2 minutes late, but thank you for all the work you do.